All right, welcome to The Explainer. Today, we are diving headfirst into one of the most terrifying scenarios in medicine, a catastrophic injury deep inside the body. We're talking about a race against the clock where surgeons have mere minutes to stop someone from bleeding to death. This is the world of abdominal vascular trauma. So get this, a staggering 90%. That's the number of these major abdominal vessel injuries in urban trauma centers that come from penetrating trauma. Think gunshot wounds, stab wounds, anything that pierces the body. The second a bullet or a blade tears through one of those massive blood vessels, the countdown begins. The clock is officially, terrifyingly, ticking.
And here's why that's so incredibly dangerous. A hit to a major vessel. I mean, we're not talking about a small leak here. This is a full-on, catastrophic internal bleed. You can lose your entire blood volume in just a few minutes. It is, without a doubt, a surgeon's absolute worst nightmare.
Okay, now let's zero in on just how terrifying this can be. If we're talking about an injury to the big one, the abdominal aorta, the body's largest artery, the mortality rate is a brutal 67%. I mean, think about that. The moment that injury happens, the odds are already stacked way, way against you.
So the big question is, how on earth do surgeons fight back against these kinds of odds? Well, what's really fascinating is that their strategy doesn't start in the sterile environment of an operating room. Nope, it begins on the street, sometimes miles and miles away from the hospital.
Yeah, that's right. For someone with this kind of injury, the battle for survival starts right there on the scene. It's happening in the back of the ambulance, long before they ever see the inside of a hospital.
The number one priority out there? It's shockingly simple. Just get to a surgeon. Fast. The whole strategy is called scoop and run. It basically means forget trying to do fancy procedures in the field. The most important thing is getting that patient to a trauma center. Because at the end of the day, only a surgeon's hands can physically stop that bleeding.
Now, this is where things get a little weird, kind of counterintuitive. Your first instinct might be to pump the patient full of fluids to raise their blood pressure, right? Wrong. Turns out, aggressively jacking up the blood pressure can actually blow out any little clots the body has managed to form, making the bleeding way worse. So instead, paramedics and ER docs aim for something called controlled hypotension. The idea is to keep the blood pressure just high enough to get blood to the brain and kidneys, but low enough that you're not just, well, fueling the fire.
Okay, so the patient makes it to the hospital. The second they crash through those ER doors, the entire team's focus just narrows down to one single all-important question. And the answer to this question determines everything that happens next. And that question is this: is the patient hemodynamically stable or unstable? You know, are their vitals holding on, or are they crashing and burning? Is their blood pressure in the basement and their heart rate going through the roof? The answer to that question sends them down one of two very different paths. It's a critical fork in the road.
And you can see that divide right here. If a patient is unstable, they bypass everything. No waiting, no tests, they go straight to the operating room, period. Time is a luxury they just don't have. But if they're stable, if their body is somehow managing to keep things together for a moment, that might buy the team just enough time for a quick CT scan to figure out exactly where the damage is.
All right, so now we're in the OR. And for the surgeon, it's like entering a war zone. They have to navigate this incredibly complex, blood-filled landscape where all the normal landmarks, all the normal anatomy is just gone, obscured. And every single move they make is absolutely critical.
And a lot of the time, the source of all this chaos is hidden deep inside the retroperitoneum. Now, this isn't some open space. It's this tightly packed area behind your abdominal lining, and it's full of the biggest blood vessels in your body, plus your kidneys, your pancreas, all kinds of vital stuff. It's super hard to get to, and it takes some serious surgical skill just to open it up and see what's going on.
So to deal with this chaos, surgeons use a kind of mental map. They divide that whole area up into 4 zones. You've got Zone 1, that's the midline, with the aorta and vena cava. Zone 2 is out to the sides with the kidneys. Zone 3 is way down in the pelvis, and Zone 4 is tucked up behind the liver. This system helps them work through the mess methodically and find the source of the bleeding much, much faster.
Once they find the injury, the game plan follows 3 core principles. Step 1, put a hand on it. Simple direct pressure. Step 2, get control of the vessel both upstream and downstream from the hole. And step 3, if things are really bad, they go for the nuclear option, cross-clamping the aorta high up at the diaphragm. This literally shuts off all blood flow to the entire lower half of the body. It's as dramatic as it sounds.
But what if the injury is just too massive? What if the patient is so fragile that a long, complicated repair just isn't an option?
Well, sometimes the smartest, most life-saving thing a surgeon can do isn't to fix everything. It's to stage a tactical retreat.
This is a really critical moment in trauma surgery. You have to realize a patient who's bleeding this much is right on the edge of a total physiological collapse. If you try to push for some perfect textbook repair that's going to take hours, you could literally kill them right there on the operating table.
And the reason for that is something called the lethal triad, is this horrible downward spiral. See, all that bleeding makes the patient's body temperature drop. That's hypothermia. Then, the poor circulation makes their blood acidic. And here's the kicker. Cold, acidic blood can't clot properly, so they just keep bleeding more, which makes them colder and more acidic. You see the problem? It's a vicious, self-perpetuating cycle of death.
So the surgeon has to completely shift gears. They move away from the idea of a definitive repair and switch to a strategy called damage control surgery. The goal is no longer about making everything perfect. The new goals are simple. 1. Stop the massive bleeding. 2. Control any contamination, like from a busted intestine. And 3. Get the patient off the table and into the ICU as fast as humanly possible.
And the techniques they use are just brilliantly pragmatic. We're talking about things like tightly packing the entire abdomen with gauze to just put pressure on everything and soak up the blood. If a major artery is destroyed, forget a complex graft. They'll stick a temporary plastic tube in there, a shunt, just to keep blood flowing down to the leg. The whole philosophy is, save the life now, worry about fixing the anatomy later.
But even if that surgery is a success, even if the patient makes it through the night in the ICU, they are absolutely not out of the woods. The fight is far from over. In fact, the consequences of the initial injury and the massive resuscitation effort start to create brand new life-threatening problems.
One of the biggest threats after a surgery like this is something called abdominal compartment syndrome. Think about it. All those fluids that were pumped into the patient, plus the massive inflammation from the injury itself, cause all the organs and intestines to just swell up like crazy. This jacks up the pressure inside the abdomen to deadly levels, literally crushing the organs and cutting off their blood flow.
And there's really only one solution. You have to relieve that pressure. This is why, after a damage control surgery, surgeons often won't even close the patient's skin. They'll leave the abdomen open, cover it with a sterile plastic sheet, and give all those swollen organs room to expand without causing more damage.
But despite how grim all this sounds, the future is actually incredibly promising. We are seeing a revolution in trauma care. There are now endovascular techniques where surgeons can go inside the blood vessels with catheters to blow up balloons or place stents to stop the bleeding from the inside out. We have hybrid operating rooms that mix traditional surgery with live, high-tech imaging. And there are new drugs and agents that can help blood clot faster than ever before.
It's this relentless pace of innovation, all the way from the simple, brilliant idea of scoop and run to the absolute high-tech wizardry of these new endovascular repairs. It's all working to turn what was once a near-certain death sentence into a survivable injury. But the ultimate question still hangs in the air. Can all this new technology and all these new strategies finally conquer one of surgery's absolute deadliest challenges for good?